Good afternoon, everyone. Welcome to the Translational Science Seminar series in January. And this is our first seminar series with a focus on policy this semester. Our first speaker, as you know, is Dr. Paul Simon, the Chief Science Officer of the LA County Department of Public Health, and I'll give his introduction in a moment. But I wanted to highlight the other lectures that are coming our way. And if you were interested, there will be a sign up. There's a sign up at the CTSI website. So the other lectures will be, one will be February 24th, and the other one will be March 17th. The one in February will be on translating COVID science into school policy, insights from school administrators. And the one on March 17th will be when best practices fail, nuances of using narratives and research dissemination to policymakers. I'm very pleased today to have with us Dr. Paul Simon, who is the Chief Science Officer at the LA County Department of Public Health and an adjunct professor in the Department of Epidemiology at the UCLA Fielding School of Public Health. Dr. Simon received his MD from the University of Michigan School of Medicine and his MPH in epidemiology from the UCLA Fielding School of Public Health. He completed a 2-year fellowship in field epidemiology with the Epidemic Intelligence Service at the Centers for Disease Control and Prevention. He then served as a medical epidemiologist in the Division of HIV and AIDS Prevention at the CDC before joining the LA County Department of Health, where he was the director of the Office of Health Assessment and Epidemiology and the director of the Division of Chronic Disease and Injury Prevention before assuming his current position. Dr. Simon is board certified in pediatrics and preventative medicine. Dr. Simon, thank you so much for joining us today, and we really look forward to listening to your talk.
Thanks so much, Charlene, and hello, everyone. Pleasure to be here. Happy to talk about a topic that I think is extremely important, but also I think underappreciated by most of the general public and even among policymakers. I want to underscore that I'm really going to provide a local health department perspective, though I will also provide some historical perspective more generally as well. So let me see if I can, great. Did that? Yeah, there we go. Okay, so I'll spend a little bit of time just describing LA County and our department.
Paul, if I could interject, just that green button, the share screen, if you could pick the open window of the PowerPoint to share that. We're not seeing a share.
Oh, let's see here. Let me end show for a moment.
No problem.
So I'm not seeing.
In the Zoom window, so you're going to go to the Zoom meeting window, there's a green button, share screen, and that'll allow you to choose the PowerPoint window that you'd like to share.
Okay. There we go.
There you go.
Great. Okay, so everybody can see the slide?
You look good.
Great. So I'll begin by just describing LA County and then spend some time talking about why we view policy to be so important for public health. Describe a little bit about the policy work we do in the department, and then provide some thoughts about how we can all maximize the value of policy research. And then I'll close with just some general reflections. So first, LA County, as everyone knows, is really a gigantic place. It has over 4,000 square miles. There are 88 incorporated cities within the county, which creates lots of opportunity for policy. I sometimes describe LA County as a laboratory of innovation, because we can often identify at least a few cities that are willing to try new things that are forward thinking. And then if those policy initiatives are successful, then we work to spread that across the county, across the other cities. We also do have a large unincorporated area as well. About 1 million of our 10 million residents live in unincorporated areas that are governed by our county board of supervisors. And so that offers, again, more opportunity for policy. 81 school districts, by far the largest LA Unified School District. But again, with such a large number of school districts, we can try a number of different things with different districts depending upon their receptivity. With over just actually now about 10 million residents, we're more populous than 41 states. We have a lot of racial and ethnic diversity. We are approaching, though, majority Latino population. A great deal of socioeconomic variation across the county, with some of the richest and then some of the poorest communities in the country, sometimes located in close proximity. So we have a very large public health department. We're the public health authority for the entire county, except for 2 cities, Pasadena and Long Beach. They have their own city health departments. But otherwise, we sort of manage all public health. The vision of our department: healthy people and healthy communities, recognizing that it's very difficult to have a healthy population if we don't have community conditions that support health. Our mission to advance the conditions that support optimal health and well-being for all. While health equity is not explicitly called out in this mission, we have, over the past 10, 15 years, focused a great deal on health equity. We established a Center for Health Equity about five years ago or so, and all of our programs are expected to embed health equity principles into their work plans. Our department is very large. Prior to COVID, our budget was about $1.3 billion annually. With the infusion of COVID funding, the budget went up to about $2.5 billion. It's now slowly coming back down, which is presenting lots of challenges for us because we established quite an impressive infrastructure with many talented contract employees, and now trying to retain as many of those staff as possible. 8 divisions, about 40 programs, just covering a wide range of different programmatic efforts. But over 4,000 employees. Prior to the pandemic, more recently, we somewhere around 5,500 employees. So we really got quite a bit larger with the COVID pandemic. So it's hard for me to believe that almost 35 years have passed since this report came out. The Future of Public Health, published by the Institute of Medicine, which was the forerunner of the National Academy of Medicine. This was really a seminal report. It described at the time public health as being in disarray, and it charted sort of a roadmap for how public health, particularly government public health. This initial report was focused primarily on government public health agencies, but how they could forge a more productive path moving forward. And they described 3 core functions: assessment, assurance, assessment essentially being surveillance and population health assessment, assurance being the assurance of all necessary services, not necessarily the direct delivery of all those services, but delivering some and then ensuring that other needed services are available across communities. And then policy development, a core function of public health, very, I think, under-recognized, underappreciated at that time, and even to this day. While those of us working in public health departments recognize the importance of policy, I think many in the public don't recognize its importance, and even policymakers often don't appreciate the opportunities really to use policy to improve population health and reduce health inequities, particularly as we think about reducing health inequities. So looking back over the 20th century, I think many are aware that we've had great success in reducing morbidity and mortality from infectious diseases. Of course, now the pandemic going on 3 years has reversed a lot of that progress, unfortunately. But as shown in this slide, which charts the trend in mortality from infectious diseases across the 20th century, a dramatic decline in infectious disease mortality. And what I think is surprising to many about this slide, though, is that much of the decline occurred prior to the introduction of antibiotics, prior to the introduction of mass vaccination, with the exception of the influenza pandemic. You can see prior to 1940, quite a bit of decline in infectious disease mortality. And this really related to policy work to improve community conditions. For example, more modern systems of sanitation, potable water, improved working conditions, regulations that mandated certain standards for workplaces and for housing that improved ventilation. The leading causes of death in 1900 were tuberculosis and other respiratory illnesses and diarrheal diseases. And so, for example, by improving ventilation in workplaces and in housing, we were able to greatly reduce respiratory disease-related morbidity and mortality. And you can see to the far right, a bit of a bump up in the latter part, the last decade or two of the 20th century related to the HIV and AIDS pandemic. And I'll talk about COVID in a little bit later. But there are other examples. And this is one of the most dramatic I've seen, really, of the power of policy. In the 70s and 80s, there were efforts and policies to remove lead from gasoline and from paint. And you can see the National Health and Nutrition Examination Survey results, a nationally representative sample, lead levels among children ages 1 through 5. And this makes me shudder because I was a young child in the late 50s and 60s. So this is probably what I was walking around with as well, a relatively high lead level. And we know that lead is very toxic to developing brains and nervous systems in young children. And so you can see in 1976 through 1980, more than 3/4 of children ages 1 to 5 had a lead level greater than 10 or greater micrograms per deciliter. But that then dropped dramatically by the early 90s and even further by the beginning of this century. Similarly, around injury prevention, dramatic process. This slide shows deaths over time. Well, actually rates. The denominator is interesting, not just the population, but actually vehicle miles traveled. And so that red dotted line shows how vehicle miles traveled went up. And then if you look at the death rate per vehicle mile traveled, a dramatic decline over the 20th century. And again, related primarily to policy efforts. It wasn't, there were education efforts, but frankly, when it comes to injury prevention, and I speak as a former pediatrician, where we focus a lot on educating families. Education really, when it comes to injury prevention, has unfortunately limited effectiveness. And the greatest success really has been creating safer environments. And much of that is done through policy. And so, for example, creating safer roadways, transportation engineering really became a well-established profession. Speed limits, manufacturing safer automobiles, mandating seatbelts and car seats. We take these things for granted today, but these involve really difficult policy battles. It wasn't easy, for example, to get the automobile industry in the 60s and 70s to establish or build in sort of engineering that enhanced safety or to include seatbelts. Believe it or not, that was not popular. But very quickly after the policies were established and the auto industry recognized the marketing advantage as the public became more aware and valued, obviously, being in a safe car, the industry really saw then the marketing advantage, and then they really embraced it, and safety features have been enhanced over time. And this, another great example of how policy can impact behavior, dramatic reductions in smoking after the first Surgeon General's report in 1964, but then a whole cascade of policies restricting advertising, for example, taxation of tobacco products, and then restricting where where smoking could be done, and how products could be sold and marketed. And in LA County, we've had a very robust tobacco control program. And this slide shows, again, working across our 88 cities and our county unincorporated area, how many policies were passed over just an 18-year period from 2004 to 2022. 51 jurisdictions established tobacco retail licensing policies, and essentially what that does is it requires retailers who sell tobacco to pay a licensing fee, and that fee is then used for a variety of activities. One, to educate retailers about the need to not sell to minors, but also it funded us to do sting operations to identify retailers who are not adhering to the law, and that even though we only did that in a minority of retailers, that the knowledge that we were doing that resulted in a lot more adherence among tobacco retailers. Smoke-free outdoor areas. We actually have a couple cities. Well, actually, I was going to back to retail licensing. Beverly Hills and Manhattan have restricted sale of all tobacco products. And there are a couple cities that have actually prohibited smoking in all areas of the city. But many cities that have passed, well, early on, smoke-free beaches, smoke-free parks, more recently, smoke-free outdoor dining. Back in the 1990s, the state passed policies to restrict smoking in bars and restaurants. Smoke-free multi-unit housing, 19 jurisdictions. This, though, sort of underscores sometimes the tension between different policy needs. We have a real problem here with affordable housing. And so as there's been work to push this smoke-free multi-unit housing policy, it has worked against efforts, though, to provide affordable housing to all who need it, particularly people who smoke and unable to quit smoking. So this has not been a universally popular policy direction for us. And so we do have quite a low rate of smoking in LA County, with not dramatic progress since 2002, but at least some. Our smoking rate, I think, is lower than any state across the country except for Utah, the last I looked. And a much more dramatic decline in smoking prevalence among high school students. And this has been reported, I think, in a number of jurisdictions across the country. But back in 1997, 1 in 4 high school students said yes to the question they'd smoked 1 or more cigarettes in the past 30 days. By 2019, it was down to 2.3%. Some of that reflects policy. For example, taxation. We've had several tax measures raising the price of tobacco products, and we know that youth are very price sensitive. As the price goes up, consumption goes down. But in addition, there was a very effective social marketing campaign initiated around 2000 called the Truth Campaign that probably many of you heard about, that was very successful and changed social norms around smoking among adolescents. Of course, this slide does not show e-cigarette use. We have some data on that. It's not very, there's a lot of variation. I'm not confident of the accuracy of the data, but we think somewhere around 15% of youth will report e-cigarette use. So it's not a universally positive trend, but combustible tobacco is a lot more toxic than e-cigarettes. And we believe actually that there will, in the next few years, be a continued decline in combustible tobacco use, but also a decline in e-cigarette use, because the state passed a law that bans all flavored or almost flavored tobacco products, including e-cigarettes, including menthol, by the way, which will reduce tobacco use in the African-American population. So we're really proud of that. The other big issue that I worked on for 9 years that was extremely challenging was addressing obesity and diabetes in the county. And you can see here from our LA County Health Survey that obesity rates have gone up quite dramatically from 1997 through 2018. The obesity rate doubled, and the self-reported rate of diabetes, mostly type 2 diabetes, also doubled. And we found a dramatic variation across cities and communities in the county. So this shows childhood obesity prevalence using data we get from schools. And on the left, the cities and communities with the lowest child obesity rates. And if you're familiar with LA County, you can see that many of these are among the most affluent in the county, whereas on the right, those with the highest child obesity rates, these are among the poorest communities. And you can see the lowest prevalence, Manhattan Beach, 2.8%. The average in this group, 7.2%. The other extreme, South El Monte, this was back in 2010, 34%, more than 1 in 3 children obese, and the average 30.7%. So the children in these communities face very different futures than those in these more privileged, affluent communities. And so we have a large nutrition and physical activity program that's doing a lot of nutrition education, some policy work, although not as bold as I would like, but the work is dictated, I think, by the federal funder. But we did establish what I felt at the time was a very innovative program. Now a number of health departments have similar programs. It was called the PLACE program, Policies for Livable, Active Communities and Environments. Mission to foster policy change that supports the development of healthier environments where we live, work, and play. Early focus on physical activity and food environments. More recent focus on community safety. They've embraced this Vision Zero initiative that is really a global initiative, trying to reduce traffic-related mortality and morbidity, severe injuries. This program really was a major shift for us away from just sort of handing funding out to community organizations to provide direct services and education, which is important work. Don't want to diminish its importance, but this program focused more specifically on working with cities around land use planning, transportation planning, and policy to create more walkable and bikeable communities and healthier food environments. We've had a lot of success around promoting environments that support physical activity, much more of a challenge around trying to influence food environments and create healthier food environments. We also created in 2013 a Center for Health Impact Evaluation that does policy analysis, also does health impact assessments. You can see at the bottom of the slide some examples of studies, analyses they've done, and we have reports for all of these on our website. The link is shown at the bottom. One that was particularly interesting recently was the group, and it's a small group, only 4 or 5 staff, but a very visible group. In fact, it's one of the rare examples of a program that got started with grant funding. The grant funding went away, but it was valued enough that our Board of Supervisors was willing to continue to fund it with county dollars, which is saying something given the scarcity of county dollars and the competition for county funding to work. This analysis, though, was requested by our board. The state had passed a law around 2017 legalizing recreational use of marijuana in adults 21 and older. There had been medicinal marijuana legality going further back in time, but this was broader use of marijuana cannabis products. The state does regulation, the state does taxation, but it also gave local jurisdictions authority to do additional taxation and regulation. In fact, cities could choose whether or not they wanted to allow cannabis retailers. And our board wanted to know, should we, in our unincorporated areas, now allow cannabis retailers? And so our group did an analysis of what the health equity impacts might be. Well, very quickly, just highlight some of the findings. I'll read through this quickly. We did find unlicensed dispensaries were more concentrated in health disadvantaged areas than licensed dispensaries, because some cities had already adopted the law and allowing retailers in their cities. Crime was more prevalent near unlicensed dispensaries. The black-white disparity in cannabis-related ER visits had doubled from 2012 to 2017. Unlicensed businesses were more likely to engage in health-harming practices. Interestingly, areas of the county with early licensing saw declines in the number of unlicensed dispensaries. Those that maintained the ban actually saw an increase in unlicensed dispensaries. Youth in lower income schools were more likely to use cannabis than those in higher income schools. Medicinal users reported increased difficulty obtaining preferred products, and many were unaware of the medical marijuana ID program and were afraid to use it. So anyway, there were a number of recommendations made. I won't read through these, but it was a report that was embraced by our board. And I'm actually forgetting now when I believe they did then allow they did move forward with allowing retailers in unincorporated areas, but with some provisos. I want to just sort of close with our experience around COVID. We saw our first case of COVID in January of 2020, and then very rapidly, as in other areas, an increase in cases and deaths. And so just in the space of 1 year, from 2019 to 2020, we saw that COVID became the second leading cause of death behind coronary heart disease, but it surpassed all other causes of death in the county. And even more dramatic impact on premature mortality in the county. It became the leading cause of premature death in the county. And some in LA County and across the country argue that we were inflating the statistics, that we and healthcare providers somehow had some incentive to put COVID on the death certificate, and that the mortality increase wasn't real. So we actually looked at all-cause mortality to see what the impact was. And you can see from 2011 through 2019, fairly steady, unchanging rates of mortality. Sadly, very large disparities by race and ethnicity, and with no real success in narrowing those disparities. Then in 2020, with the pandemic, a dramatic increase in all-cause mortality. The greatest increase proportionally actually was in the Latino population, that green line, but also quite a large increase in the African-American population, significant, though slightly less, increase in the Asian population, and then an increase, but proportionally less, in the white population, the blue line. And the so-called Latino paradox, longstanding Latino mortality paradox, the lower mortality rate among Latinos than whites, despite the fact that they have a much higher rate of poverty. That paradox, that mortality advantage, was obliterated with the pandemic. You can see the green line now goes above the blue line on the far right, and continued to worsen in 2021. The Latino population was the one population that continued to see an increase in mortality in 2021. So we, like many others, did a lot to address the pandemic. I would say LA County on the spectrum of responses, we were probably more aggressive than many, and we faced a lot of heat from a number of different individuals and groups across the county about some of the policies that we established to control the pandemic. I'm particularly interested actually in your next session, where you're going to talk about policy in schools. It's been very controversial here. But the pandemic has raised a number of very challenging policy questions. How long should we have maintained our stay-at-home order, where we virtually shut down our society here and across the country, but some places opened up more quickly than we did. We kept schools closed for quite some time. In many other places, schools were opened more quickly. There's been a lot of debate about the role of mask mandates. We've been pretty aggressive on that. How we managed isolation and quarantine orders, how long should one be isolated? There's been a lot of question about the efficacy of our isolation and quarantine, given the relatively short incubation period, and with the newer variants, even shorter incubation periods of the virus. The role of vaccine mandates. There was a short period of time where the city of LA and the county were requiring vaccination to get into certain venues. What's the role of mandated screening and testing in high-risk venues? Should sanctions be imposed on healthcare providers who disseminate misinformation? And how do you define dissemination of misinformation? All really challenging questions. Clearly, the research that you all do and others do around policy is extremely important. Identifying effective policy interventions, not just identifying or quantifying the level of effectiveness of the intervention, but also recognizing and trying to quantify the trade-offs. I mentioned housing policy. For example, there's been a real push in LA County to restrict housing right next to freeways, because there's good data, good evidence that if you live in close proximity to a freeway, you have a higher risk of asthma and other adverse respiratory conditions. And so there have been efforts to restrict housing near freeways, but that works against our efforts to expand affordable housing in the county. Quantifying impacts really important, and not just the traditional sort of impacts related to healthcare or specific public health programs, but trying to quantify the impacts of policy decision-making in other sectors, so-called non-health sectors, recognizing the social determinants of health. Really important work. Comparative effectiveness studies demonstrating which interventions actually work best, and where feasible, factoring in cost, societal costs, for example, related to not doing something, cost effectiveness, not just lives saved, morbidity and disability reduced, but factoring in cost savings as well. The policymakers respond very much to that sort of information. Although I will say, unfortunately, science and research is not a panacea. There are lots of examples of policies that have a strong evidence base, but nonetheless aren't embraced by policymakers due to, ideological sort of beliefs. And then maximizing value. I think we tend to be a little bit cautious about single studies, and we find it very helpful when we see systematic reviews. In addition to the big P, government policy, it's really helpful to have research that focuses on what we call little p, or organizational policy. Implementation science, really important in this realm. Not just studying the effectiveness or the impact of particular policy, but also understanding what methods are most effective in getting policies adopted. And then once adopted, how do you best ensure implementation? Often you get the policy passed and then everybody forgets. Not everybody, not always the advocates, but too many others forget about the importance of implementation and actually then evaluating adherence and impact. Assessing equity impacts. A lot of the trend lines I showed were just overall population trend lines, but really important to understand whether a policy is narrowing those gaps between different groups. And then communication is really important. As academics, And even though I work in a health department, I think I'm guilty at times as well. I do have an affiliation with UCLA. We tend to love to present stuff, with all the technical aspects included. But when it comes to influencing the public and policymakers, the messaging needs to be much more straightforward. We need to understand who are the best messengers. As government workers, we're often not necessarily trusted messengers. And in fact, we rely increasingly on community leaders, community partners to deliver messages. And then segmentation, targeting your audience. Who are you trying to influence? The messaging you do for the general public may be very different than the messaging you do, for example, to a city council or a school board. So understanding the audience and then targeting the message to that audience is really important. I'll just close with a few reflections which focus on challenges, because that's really what came to mind as I thought about this presentation. What the pandemic has highlighted is that we need research sometimes that can happen very rapidly. We were operating throughout this pandemic with incomplete information and often then having to change course. And that created, I think, lots of confusion in the minds of the public and increased levels of distrust because we had to change recommendations at different points in time. And having research, and I think the research community did really step up. There was just, a mountain of research. It's all impossible to keep up with all of it. A lot of it now, pre-peer reviewed research, which takes me, I think, to, my fourth bullet. How do you evaluate the evidence base in the context of an explosive increase in, quote, published research? There's been just a proliferation of journals with highly variable quality. So we as consumers of that research need to be, I think, very, scrutinizing of the quality. But back up to the second bullet, I think we have a hard time communicating the uncertainty inherent in the scientific enterprise, that, science advances incrementally. And with any given study, you state conclusions, but there are all study limitations and some level of uncertainty. Minimizing bias, there's publication bias, positive results more likely to be published than negative results. Researcher bias, I saw this very clearly when I was working in chronic disease prevention, where some researchers really become very strong advocates. And that's important, but I worry sometimes that can influence the scientific enterprise, the research enterprise. And then the last bullet, combating a very significantly growing anti-science movement has been, challenging. So I'll stop there. Happy to answer any questions or, welcome any thoughts. Interested in it. Doesn't need to be just question and answer. Happy to have a discussion.
Thank you so much, Dr. Simon. That was really very thought-provoking, particularly your last few slides. I'll start off the Q&A session with my own. I'll take the liberty of doing that. But if anyone has any questions, you're welcome to put it into the chat box, or you can raise your hand. The question that I had was that, you mentioned some, what I would say is, advice to researchers who are looking to better disseminate their research to policymakers. I heard you say something about, systematic reviews, rapid research, sort of minimizing researcher bias, and, finding that balance between advocacy and research. But I was wondering if you had any other sorts of thoughts. What can researchers do to increase the policy relevance of their work? And, if there's any kind of just general advice that you might give.
Yeah, I'm reminded of advice that was shared by a state epidemiologist at the time, a guy named Mike Osterholm, who's now, I think, at University of Minnesota. This was many years ago when I was at the CDC, where he talked about consequential epidemiology. That, it takes some effort to really identify what the key issues are. And I think following the news, having a connection with whatever community you serve, and understanding sort of what the hot button issues are, and then formulating the research question to be as responsive as possible to those critical issues. Timing is everything. And our Center for Health Impact Evaluation has found it very challenging to do health impact assessments that are influential, because they learn about a policy that's being considered, and within a year or so, a decision is being made. So they need to do their health impact assessment very quickly. So sort of being facile and able to do research, even if it's sort of quick and dirty. It may not necessarily at first blush be rigorous enough to get into a peer-reviewed journal, but it may be good enough to inform a policy decision. So looking for policies that are being considered by a local policymaking entity, or a regional or even national entity. And then on the back end, once the research has been done, working with many universities have actually a public information's office. I've done, with the COVID pandemic, lots of collaboration with folks at USC. We did early on some research looking at the seroprevalence of COVID antibodies, SARS-CoV-2 antibody in the population, to get a sense of how widespread the pandemic was early on, recognizing we were probably only capturing the tip of the iceberg with our surveillance, identifying COVID cases. And we found indeed that a much larger percentage of the population by the spring of 2020 had already been infected with SARS-CoV-2. And it got a lot of news coverage. My colleague Niraj Sood and I were overwhelmed with, for about several weeks, media interviews. And one of the reasons was USC had a very, very sophisticated media relations office, and they promoted the research very effectively. As scientists and public health practitioners, we don't often think about this. What are the strategies to get your work out there? And I think having and I'm not sure if, Penn State, I know, is well represented here. I'm not sure what other universities are represented by people listening in, but to identify at your institution, the public, it can be called different things, press office, public information office, media relations office, but identify that office, have a strong connection with the director of that office to make sure that your work gets out there in the most strategic way possible. We're not, as researchers, we're not into marketing, but these folks are and can help really get your work out there.
Thank you. And if I can just put in a plug for, so you had mentioned that you're interested in the second lecture, which is about a school response to COVID. The third lecture is actually about a randomized trial that a Penn State researcher has done, looking at communications to policymakers and what increases the likelihood that that policymakers will click on the links. So
fascinating.
Yeah, so I think that these are all wonderful questions. We have a couple of questions. One housekeeping question, which is that about the slides being available, and Ellie will send the slides out to everyone. We have a question from Leva Bloomberger, which is, on one of your slides, you discussed the rising rate of overdoses between 2019 and 2020. Has there been major differences in policy perspectives between policymakers and the public about addressing overdoses within the county? And if so, how have they been addressed?
Can you repeat the last part of that question? Has there been differences? What was that?
In policy perspectives between policymakers and the public about addressing overdoses? And if so, have they been addressed?
Yeah, this has been a big, big focus. We were so distracted well, distracted is not the right word. We had to shift so significantly over to COVID response that we had to drop a lot of our other work in the health department, sadly. But one area that did continue to, focus pretty intensively was we have a substance abuse prevention and control program, and a major area of their work is trying to reduce drug overdose deaths, and it has been a significant issue here. I will say I don't think we've had a great deal of success in addressing it so far. What was the last part of the question, though? I'm forgetting. I want to make sure I address the question correctly.
The last question was just, thinking about the differences in policy perspectives between policymakers and the public, and then if sort of how those differences have been addressed.
But was specifically related to drug overdose?
Yes.
Yeah, I think we all recognize it's a significant problem, but I don't think we've found the needed solutions, to be honest. Yeah, so I don't have much more to say on that. I'm not sure what the questioner was getting at. If maybe the questioner had something more specific in mind, I'd be happy to hear.
And Liba, you're welcome to chime in here, but I just wanted to say that, one of the challenges I imagine, you were mentioning that you had to shift dramatically to COVID, was that as a health department, you potentially need to be focusing on, have sort of one central message. And I would imagine that sometimes means that, not exactly secondary, but sort of alternative issues might sometimes get pushed aside. And I would imagine that could be a big challenge, particularly, not just because of, messaging grounds, but I would imagine that there might also be a problem with, in terms of resources.
Yes. Now, our substance abuse prevention and control program is the largest division funding-wise in our department. It's a massive. And we did our best actually to try to leave that group alone. We detailed a very large number of our staff over to the COVID response, particularly in the first year. But we tried to leave the SAPSI program alone as much as possible, because the drug overdose issue is really a very, very significant problem in our county. I can't say that we've made the progress that we would like in that area, but I know there are a lot of active efforts to try to reduce the toll of drug overdose deaths in the county.
You were mentioning earlier about sort of tension between different competing policy aims. So the example you'd given was on affordable housing versus, both health effects of highways, but then also smoking and multi-unit housing. And I'm wondering, do researchers ever play a role in helping address those sort of competing policy aims, or is it really, more on a policy/political level that these decisions are being made?
Yeah, unfortunately, I think practitioners and researchers tend to focus on their policy and advocate for their policy. And I think one of the strengths of this whole movement around health impact assessment has been that it involves actually considering competing priorities, competing risks. So ideally, you will build into your analysis what the benefits and costs, not just monetary costs, but health costs of different policy directions. So yeah, I would say, unfortunately, most researchers, well, I hate to characterize all researchers, but many, let's say many that I work with at least, and many of our program directors tend to be sort of single issue, advocates. And I think one of the really important contributions of health impact assessment has been to force us to consider not only the benefits, but the potential trade-offs of a particular policy direction and sort of competing, benefits versus risks of varying policy options.
I think that's a great thing, and it seems like something that would be useful for researchers to keep in mind, the sort of thinking about having a broader perspective of how the different policies intersect. We have another question from the audience. So Lee Wang asked, could you elaborate on the effect of the banning of flavored tobacco on smokers in California? The law was passed in 2020 and upheld later. How is the health effect so far? Votes.
Yeah, we have something called the LA County Health Survey that we do ideally every 2 to 3 years, where we measure lots of different things, including health behaviors. The last survey we were able to do was 2018. We're now in the field with our next survey. So it's hard to know what the impacts of the more recent, tobacco policy initiatives have been. I probably will have an answer for you. We're in the field now, and we should have data by middle of this year to know what the most current trends are in smoking, tobacco use rates in the county. So it's hard to know, but certainly, flavored tobacco is a priority given its, appeal with youth.
Thank you. And we have, this may be the last question, or we may have time for one more from Pooh Bai, which says, thank you for the introduction and your thorough explanations. You were mentioning about the adherence to policy implementation. I wonder how researchers at the policymaking design point ensure that different stakeholders in the system react and work as a coalition, if needed, and feel obligated to perform until reaching a sustainable point. And how does that vary in different places, meaning Los Angeles versus Pennsylvania? So I think that, sorry.
That's a great question. In LA County, we've adopted something we call the policy adoption model. And I think we've published on this. And it's a collaborative model with community advocates. And we work with them throughout the policy development process. So it's advocacy on the front end, and working with whatever the policymaking entity is. It may be a city or a school district, making sure the policy is crafted in a way that we feel will be most beneficial, and then a very organized sort of advocacy effort to get the needed votes to get the policy passed, but then not stopping once the policy has been passed, making sure that the policy is being implemented in an effective way. So it's a very structured approach we use, and I'd be glad to share the reference. It was created for us by a consultant in California. It's called the Policy Adoption Model, and it's been very helpful for us. And I think an important feature really is the partnership with community stakeholders to make sure that a policy is crafted in the most, effective way, but not then, and then a very, very organized process to increase the probability that it'll be passed. It's a very structured organizing process to increase the probability it'll be passed. And then also remembering that it's not just about passing a policy, but implementing a policy, evaluating the impacts of the policy, making mid-course corrections, if needed in implementing a particular policy. So it's a very structured approach called the policy adoption model.
Thank you. I think people would be very interested in that.
So Charlene, I can send that to you. I think we have at least one paper published on this. Happy to share. And I don't think our department we can take credit, I think, for encouraging the work in this area, but it was a consultant group that developed the model. And then we, I think, have had a lot of experience implementing the policy adoption model here in LA County. And it really has resulted in a lot of success in getting tobacco control policies passed amongst our 88 cities. Been very successful. We tried to apply it actually in the obesity prevention realm around nutrition policy and physical activity policy with mixed success. But we may have published actually one paper on that as well, applying that model. If I can find that, I'll share that as well.
Great, thank you so much. And I know that you also sent along some other useful links, and I will ask Ellie if she can also send that along with the slides to people who may be interested in those materials.
There's an organization out here called Change Lab Solutions based up in the Bay Area that's very helpful organization when it comes to policy initiatives and strategy and what's evidence-based.
We do have one last question, although I'm looking at the time and I'm not sure that you'll be able to answer this. But the question was from Karen Cielo, and it is, what about potential legal challenges to policies? Does the policy adoption model assist with that?
That's a great question. Let me think for a moment about that. It doesn't explicitly address that question. It's an important question. It's interesting. At the city community level, we've not had, I'm trying to think of, probably the one area where we've had the greatest challenge is in trying to implement sugar sweetened beverage taxes. There's been a very organized, resistance by the beverage industry. They've been very effective in countering our efforts around policy in that realm. But I don't have any sort of perspective on the legal challenges to policy, but I think it's a really good question.
Well, we are just about at time. So I wanted to thank you again, Dr. Simon, for taking the time to speak with us. And I hope that everyone joins us for the next policy lecture, which again is Friday, February 24th from noon to 1 p.m. and looking at one independent school's perspective on COVID-19 policies. Thank you very much.